Hello, my name is Thomas Pereno, and this is a basic introduction to mechanical ventilation. The need for mechanical ventilation is based on the equation of motion. The equation of motion represents the total amount of pressure that needs to be generated to overcome the combination of pressure due to resistance and the pressure due to elastance. An increase in resistance, such as an asthma exacerbation, would require increased work to overcome this resistance. A condition such as intra-abdominal hypertension and ARDS would result in increased work required to overcome the stiffness of the chest wall or the lung, which is a component of the respiratory system elastance. In some cases, increased work can be due to gas exchange issues that are not directly related to resistance and elastance. There have been reports of patients with COVID-19 having a high respiratory drive with normal resistance and compliance is just the inverse of elastance. It should be noted that hypoxemia and hypercarbia can also increase drive without increased work, and COVID-19 patients that require mechanical ventilation are presenting with profound hypoxemia. Spontaneous breathing patients generate negative pressure to do this work, and the first widely used type of mechanical ventilation to assist or take over this work was based on this concept of negative pressure, the iron lung. Modern mechanical ventilation no longer uses negative pressure. Instead, it generates positive pressure to overcome this work. Non-invasive ventilation can be provided via face mask. Non-invasive ventilation is a therapy that has been shown to significantly reduce the need for intubation and mortality in patients with chronic lung and heart disease, but it has demonstrated high failure rates and lacks recommendations for patients in hypoxemic failure without chronic lung or heart disease. This is a term called de novo respiratory failure. And for this reason, it is not recommended as an approach to avoid intubation in COVID-19 patients. Invasive mechanical ventilation is delivered through an endotracheal tube and addresses the pressure required to overcome work by delivering a set pressure directly with the mode pressure assist control or the mode pressure support. It can also directly address the work of breathing by setting a flow and volume to be delivered with the mode volume assist control. In this case, the total pressure that is generated is directly related to the resistance and elastance of the respiratory system. The most common modes of ventilation have criteria for when they start, what they control, and what determines the cycling or the end of the breath that is being delivered. Volume assist control has a mandatory frequency of breaths per minute that is set. The patient can trigger all the breaths and more, but if they lack respiratory drive, the ventilator will provide the minimum set frequency. Pressure assist control has the same criteria for when a breath is delivered. Pressure support, however, requires active effort from the patient as there is no set frequency. It should be noted that a leak around the endotracheal tube and even cardiac oscillations can trigger a ventilator, giving the impression that the patient is breathing when it may not be the case. For volume assist control, the item that is controlled is the flow. Even though tidal volume is set, it is essentially the target. When the target volume is delivered by the flow that is set and controlled, the breath has ended. However, added time can be used to prolong the breath and provide a measurement of plateau pressure. This concept is covered further in the basic ventilator settings video. Pressure assist control controls the pressure in the system. It provides variable flow, essentially whatever flow is required to maintain the pressure. The pressure is maintained for a determined amount of time, which is the I time, which is a setting, and that's the point at which the breath cycles off. Pressure support also controls pressure and provides whatever flow is required to maintain it, but the cycling criteria to end the breath is based on a percentage of the peak flow. This is also further discussed in the basic ventilator settings video. Mechanical ventilation is generally separated into two goals: provide assist with minute ventilation to remove carbon dioxide, and provide FiO2 and maintain end expiratory lung volume with positive end expiratory pressure, PEEP, to maintain oxygenation. The elements that are used to adjust this, of course, are respiratory rate and tidal volume, or if using a pressure-targeted mode, you would adjust the pressure to get a tidal volume to affect minute ventilation, and of course PEEP and FiO2 for oxygenation. The breath sequence on the mechanical ventilator is defined by the flow time scalar. The inspiratory phase occurs during positive flow, above the line, and the expiratory phase occurs during negative flow, below the line. Please note that the word negative just represents the position on the waveform. It is not an active negative pressure applied. It is a completely passive process. A ventilator screen generally displays 2 or 3 scalars that consist of volume, flow, and pressure. They're not always in the same order, so you have to understand what you're looking at, keeping in mind that flow has settings, or measurements, I should say, that are above and below the line. So in this example, volume is on the top, flow is in the middle, and pressure is on the bottom. Measured values are typically displayed as large numbers on either the side of the screens or at the top, and ventilator settings normally appear across the bottom. Software buttons or hardware buttons on the side of the monitor provide additional functions and access to additional settings either for that specific mode or to change to a new mode, alarm settings, and maneuvers. Of course, there's always an alarm silence button somewhere on the monitor. In this example, it's the bottom right-hand screen. Here's an example of a ventilator screen. You can see software buttons along the left side, 3 waveforms in the center, pressure at the top, flow in the middle, volume at the bottom. Settings are all along the bottom, and monitored and measured values are along the right-hand side. And there's an alarm silence button in the top left. Here's an example of an additional features graph that can be displayed either continuously or momentarily for measurements. Again, monitored values on one side and software buttons on the other side, and the ventilator settings are along the bottom. For this ventilator, the silence button is not on the screen, it is actually a hardware button on the physical monitor itself. This is an example of some of the standard ventilator measurements and standard ventilator settings. It is not a complete list because there are many modes that are not represented here. However, many of the measurements apply to all mechanical ventilation modes, such as peak pressure, plateau pressure, mean airway pressure, tidal volume, minute ventilation, etc. Probably the most common or important monitored values would be peak pressure, plateau pressure, and minute ventilation.